Good morning, US, Canada. Good afternoon, Europe, UK, and UK. Good evening, India, other Asian countries, and have a nice day ahead. I'm Suresh Malet, General Secretary and CEO of Indian Society of Radiographers and Technologists and a council member of Advisory Council member of Garcio. Today we have the fourth series of lecture, Capio and Garcio lecture, that is on artificial intelligence. I welcome all of you, all the radiographers and technologists and physicians, especially doctors, radiologists across the world of Indian origin to this webinar. Today we have Dr. Amit Gupta and Mr. Sundar Kalyana as the speakers and Dr. Vasant Venugopal as the chairperson for this session and moderator Professor S. Paneerselvam, and we have Dr. Asutosh. Good evening, Sahu also. The world is passing through a fourth industrial revolution in that artificial intelligence, machine learning, robotics, and very important. And it's a debatable subject that how the artificial intelligence will transfer or transform the entire society, especially the healthcare. In radiology, the artificial intelligence especially stands for the from image acquisition to the diagnosis and beyond. In entire healthcare, the artificial intelligence are based on the three P's: the preventive medicine, predictive medicine, and the personalized medicine. So, artificial intelligence is considered in the radiology or in the medicine, the future of medicine. Artificial intelligence is considered as the future of medicine. How we have to cope with this artificial intelligence? We have two blessed speakers, uh, Dr. Amit Gupta and Mr. Sundar Kalyana. In this session, this is moderated by Dr. Professor Paneerselvam. I wish to introduce Professor Paneerselvam. He is a well-known physicist and a blessed and very good mentor for many generations of technologies as well as radiologists. For the past 35 years, he has been training for radiologists and technologists, and especially for the FRCR exams and BSc radiology, MSc in radiology, nuclear medicine, and his life is dedicated to the continuing education of technologists, medical physicists, cardiovascular technologists, and radiologists. I welcome Professor Paneerselvam, sir, and over to Paneerselvam, sir. Thank you all.
Thank you, Mr. Suresh. Thank you for the introduction. Very good morning and good afternoon and good evening as per the zones in the different part of the globe. It's indeed a great pleasure to be a moderator for today's session. Before starting, a quick disclaimer that all the views expressed by the faculty in this webinar are their own and do not necessarily reflect or endorsed by GAPIO. And second one is the same event, whatever we are going to witness, is also available on the YouTube channel of GAPIO. So now it's a time to introduce the chairperson for this today's program, Dr. Vasant Venugopal. Dr. Vasant Venugopal is a renowned radiologist and healthcare artificial intelligence consultant with deep expertise at the intersection of clinical medicine and artificial intelligence. He currently serves as an artificial intelligence consultant at various institutes like Rajiv Gandhi Cancer Institute and Chettinad Hospital, Chennai, and is also an adjunct professor at the School of Artificial Intelligence, Amrita Institute of Medical Sciences. Formerly was the Chief Medical Officer at Kaplan, and Dr. Vasant has led artificial intelligence deployment and validation projects across diverse radiology workflows. He is a global thought leader in the safe, effective integration of AI in healthcare with a focus on algorithm robustness, clinical relevance, and human-in-the-loop oversight. With these few words, now I kindly request Dr. Vasant Venugopal take over the session and introduce the topic and the speaker. Over to Dr. Vasant sir.
Thank you, Professor Paneerselvam, and thank you for the organizing team. Thank you to Dr. Ashutosh for setting up this webinar, a very important webinar, I think, at this point of juncture. And I'll take a couple of minutes to introduce the importance of this topic today. In fact, I've been, I was a radiologist who was gone rogue, so that's how people see me. And I've spent the past close to a decade, I think 7, 8 years, uh, deeply into this field, trying to understand the promises, the reality, the failures, the threats, everything. Right now, I can with guarantee say certain things. The first and foremost thing is that the narrative is changing, right? The healthcare AI narrative, that's changing. In fact, I may use a couple of slides here to show you what I mean. So, sorry. So the healthcare AI narrative till about a couple of months, maybe till the end of last year, was that doctors with AI will be better than doctors alone. That the famous quote goes like, AI won't replace radiologists or doctors, but radiologists or doctors using AI will replace those who is not using AI. So that was a good narrative. People were happy with it. Doctors were happy with it. Radiologists were happy with it. But nobody was making any money, right? Then what's happened over the past 4, 5 months, I'm seeing is that the narrative is changing. There is a new narrative that's happening, which says that AI independently is better than even a combination of AI plus doctors. Of course, better than doctors who are not using AI. So how has that happened, right? It always starts from the top, right? The New York Times, one of the widely circulated global news magazine, published an article which called that AI chatbots defeated doctors at diagnosing illness. This found out that ChatGPT independently was doing better than even doctors using ChatGPT. Of course, better than doctors who are not using ChatGPT. Our Elon Musk picked up this news article. He said that AI will soon beat doctors and lawyers by a large margin, so on, and it went so viral. Entire Twitter space went, broke, and everyone started saying that AI should be let alone and perform alone. And it was followed up by the same New York Times with another article. In fact, this is written by one of my dear friends, Pranav Rajpurkar, which goes on to again drive the same message that the time has come for a robo doctor. Uh, Here, the message in the article, which is hidden kind of in so many lines, is that AI alone, there should be division of labor between AI, those kind of tasks, the clinical tasks, which AI can perform alone without even supervision. And then there are certain tasks where, of course, doctors can use AI and do, and then AI alone will be able to show more value than doctors using AI. The implicit message here is doctors are pulling down AI. Right, doctors are not letting AI perform to its capacity. Is what's the message that's being kind of getting pushed now, and follow it up with the first autonomous AI solution approval in Europe. Like CE gave approval for a solution called DERM, which is in fact till now, in fact it's been 3, 4 months now, the only AI solution which can autonomously do the tasks and give a report. No doctor needs to verify it. It's a dermatology solution, and people are just looking at how it is performing, how it's being taken up, so that many more such applications might come up or get approved by the European Union. Finally, again, this happened just a couple of weeks ago. Microsoft AI, to their part, came up with a new framework which they call very strategically as MyDuxo, or Microsoft AI Diagnostic Orchestra, which was shown to perform complex diagnostics tasks much better than clinicians, right? In fact, 4 times better than experienced physicians. Again, in that beautifully written blog, well-written blog, there is a kind of very sleekly placed point there, which goes on to say that perform correct diagnosis more cost effectively than physicians. So what it goes on to mean that using AI, while not only gives better performance, it's cheaper, right? The drive here is to how do we commercialize such solutions, showing them to be effective and cheaper. And again, this entire work has been criticized, evaluated. Many people have come up with feedback for the way they have done the study. But again, with all these kind of slides and presentation, what I'm trying to set the context here is the world is changing, the narrative is changing. All the big tech, from X to Microsoft to Google, everyone is pushing, pulling, putting in billions of, even in one case, there is a talk of building a AI center with up to $1 trillion. It's called Stargate. I'm sure you should be knowing. Many of you might know. $500 billion is invested in building Stargate. So much money is being put by big tech into building AI solutions for healthcare. Now, we, the clinicians or the radiographers or the physicians, physicists, all of us have a very, very important job here. Apart from our clinical role, our duty, our commitment to patient, we need to be kind of evaluating these solutions very critically, looking at them very objectively. If they perform good, if they perform safe, be open and appreciate it, acknowledge it. If not, be brave enough to call it out. Right? With that context, I would want to invite Dr. Amit Gupta. Again, Dr. Amit Gupta is a radiologist like me. He's in fact a much better and much younger radiologist than me. He is a specialist diagnostic intervention radiologist. He specializes in pediatric and onco radiology. He's from AIMS. He graduated from AIMS. He's now part of the AIMS Center of Excellence, which is set up in collaboration with IIT, and it's being funded by the government of India. It's one of the centers which fiercely fought a competition across multiple centers and won a big grant from the government. And I'm sure they're going to build so many solutions, so many frameworks that will help us evaluate these solutions more robustly. Apart from, it's easy for me to introduce Amit as someone I know, a dear friend, and much better AI person than me. I see that happening. But on top of it, he has also won several global awards. He has been awarded the EU Mini Fellowship, or the European Radiology Fellowship. He has won the FRCR top performer for the UK Radiology Certification Award. Several such awards, right? We can list it. And he's been publishing a lot, presenting at RSNA conferences. I've seen that. I will invite him now to give the first talk about why does performance metrics matter, and what do we need to know about performance metrics. While the talk is titled as radiologist, for radiologist, I'm sure the same concept can apply across the entire physician network, radiographers, and everyone. Over to you, Dr. Amit Gupta.
A very good evening to everyone from New Delhi, India, and thank you, Dr. Vasan, for such a kind introduction. I'm pretty sure that some of the part of the introduction was not correct, but we'll take it up later. So at the outset, I would like to thank the organizers for having me here, especially Dr. Ashutosh for giving me this opportunity to talk here, and I really look forward to contributing some of our experience here at AIMS and at the Center of Excellence. And so I'll dive right into the talk. So the talk for today is titled AI Model Validation and Performance Metrics. What radiologists and as Dr. Vasan said, same goes for the radiographers and all the healthcare professionals in general. We should know as clinicians, with the field of AI showing the boom and showing the growth that it is in the healthcare, as Dr. Vasan so nicely put as an introduction to the session and to the talk. So just to give you a heads up about what the next 15 to 20 minutes are going to be about. So it's a talk targeted to people, to radiologists, to radiographers who are starting to interact with AI, who are getting exposed to AI, and we'll start with an introduction to what we may call as trustworthy AI, how are these AI models validated in general, and what's the ideal practice for it? What are the most common AI tasks specifically for medical imaging that the AI models are being used for, and how do we assess the performance of AI models for these tasks using performance metrics? And finally, we'll just close out with 1 or 2 slides on how to critically assess an AI model holistically, just beyond the numerical performance metrics and actual assessment of the AI model in clinical and real world deployment. So let's start with what we can call as trustworthy AI. So if you look at the literature, there are so many virtues, so many characteristics that have been described for trustworthy AI, but the most common of them and the most important of them, we can list them out as 5 of these. That AI model should be accurate, it should be generalizable. Generalizable means it should have a performance that is good and consistent across the data sets. It should be fair, free from any bias based on gender, based on race, etc. It should be explainable, and it should preserve the privacy of the patients or the data that it is being used on. So in the talk, in the next 15 minutes, we will just talk about the accuracy and the generalizability of AI models. How do we assess it? And how do we validate the models for it? But just to give you a perspective that trustworthy AI is beyond just being an accurate and generalizable software. It's beyond it. It should be fair, it should be explainable, it should be privacy preserving. So jumping right into the model validation. So this flowchart here shows the usual flow of things, how an AI model is usually trained and then validated. What we usually start with is a data set which is labeled most commonly by experts or by other reference standards, and we split it into a training set, into a validation set. Validation set is also, we can call it as a tuning set, which is for fine tuning the AI model, or specifically the hyperparameters of the AI model. And the third split is the testing set. So the most important thing here is that this testing set here is an internal testing set, and it's an independent testing set that the model has never seen as a part of its training or as a part of its fine tuning. So this test set here is internal testing. If the model performs okay or well enough in this internal testing, it moves on to, we have to do a external testing or an external validation, which is, we can say, the real world, the real test of the AI model, wherein we take a data set from another source and we test our AI model on that data set. And even beyond the just performance of the AI model on the data sets, final and the holistic evaluation of the AI model has to be done in comparison with the conventional practice, using clinical trials, using observation studies, and so on. But so in this talk, we will be talking about more about the, you can say, the technical aspects of the AI model validation, which we will be talking more about the internal validation and the external validation of the AI models, and how do we do this validation, and how do we assess the performance of these AI models. So coming to the first step, that is the data splitting. So we have a big data set or a small data set, and it's labeled, and now we want to split it into training, validation, or testing set. So how do we split this data set? We can just randomly split this data set, right? And we can split it into 3 pieces: training set, validation set, testing set. And most common practice is to split it, like for training, we take a bigger chunk, around 70%. And for validation and test, we take 15 to 15. It can be even 60 to 20 to 20. That's based on the researchers or the team. But it's mostly the training set is set as a bigger chunk. So we can just randomly split the data. And it may work, but especially in medical data sets, the problem arises because the classes within the data set, for example, in a cancer data set, the positive data is going to be much lesser as compared to the negative data, right? So in such a scenario, what we want to use is a stratified random sampling, wherein we want to make sure that in a case of class imbalance, all the classes in the data, in the initial data, they are represented equally, or at least represented in a fair manner across all the 3 data sets, that is the training, validation, and the test set. So how we do it? We stratify first the initial data set according to the classes, and then within those classes, we randomly split the data, so that in the final sample or in the final split data set, we have representation from all the classes in all the data sets. So this is stratified sampling. Another version of it, or another more efficient but a little bit more complicated version of it, is cross-validation. Herein, we divide the training dataset into k folds, k number of folds. For example, if we divide the training dataset into 5 folds, for each training, we use a different fold of data as validation set, and we use the rest of the 4 folds for training. So for each training cycle, we can say, we use a different fold of data for validation, and we use the rest of the training set for training. So what happens by doing this is a more efficient use of data set, and it's especially useful when we are dealing with small data sets, imbalanced data sets. But again, during this cross-validation, an important point to see is that right at the outset, right at the first step, we keep a test data set which is reserved and which is not seen by the model until it is tested on this test set, and it is not seen by the model during as a part of its training data. So the test data set, the internal testing set, to be fair, to have a fair testing of the model, it should never be seen by the model during training. Okay. Another kind of scenario that arises is when we have to use group splitting. For example, let's think of a scenario where each patient has multiple mammograph images. So for one patient, we have 4 mammograms. So while splitting such a data set where there are multiple mammograms from multiple patients, we want to make sure that mammograms from one patient, they don't end up in different data sets. Why? Because in that scenario, the information may get leaked, and this is known as data leakage, which we'll see in a couple of minutes. So in such a scenario, when there are multiple images from a single patient, we want to make sure that all the images are a part of a single set, either training set or testing set. So what we do in this group splitting is we group it according to, say, the patient. So we group all the images from a single patient as one group, and taking this as a group, only then we start splitting the data set, so that at the end of it, images or information from a single group, it ends up being in a single data set. So that's group splitting. So another version of it is temporal splitting, which is quite intuitive. We can just use a data set before a cutoff date as training and after a cutoff date as testing. It's quite simple. It looks quite simple, and it's actually quite useful because it's quite representative of the real world scenario, real world deployment scenario. So all these are multiple ways of splitting data set, and we have to, the researchers or as radiologists, when we are involved in AI projects, we are training, we are developing some AI models, we have to take a call on what is the best method to split the data set that we have into training and testing. For example, just to put things into perspective, suppose we have a highly imbalanced data set of 500 mammograms, of which only 20 are positive and 480 are negative. And now we want to train an AI model on this data set, and we have to split it into training and validation and testing set. So what should we do? Should we use random, stratified, or even the fourth option seems quite attractive to me. We can keep all the positive cases in the training set so that it gets trained better. Already we have so little positive cases. So in the fourth scenario, the fourth option, we have to make sure that the model, as I said, that in cases of class imbalance, we have to make sure that all the classes are represented in the different data sets, at least fairly, so that we are able to train the model as well as test the model in a fair manner. So herein, if you're thinking stratified, then you're thinking in the right manner. So because there is such a huge class imbalance, if we just split it randomly, there are chances that we end up getting all the negative cases or all the positive cases in just one data set, and the other data set just lacks that class. Okay, so this is about data splitting. Now, once we have split the data, we have a training set, and we have a validation set, we have trained our model, and we have fine-tuned our model on our tuning set. Now we have to do internal validation on the testing set, on the internal test set. So this internal testing set, as we started with the very first slide, that this internal testing set usually is taken from the same cohort of patients, same manufacturer, same time window. The best thing, the strength of this internal testing is that it's obviously easy to acquire, right? Because we already have a data set, we just have to split it into an independent test set, which the model has not seen before. But the limitation of this internal validation or internal testing is that it's not truly generalizable. It's not representative of the real world performance of the model, because the data here comes in from quite a similar source as the training set. And that's why the internal validation does not simulate deployment. So herein comes the role of external validation. So for external validation dataset, this dataset usually or ideally should come from a different hospital, different cohort of patients, different protocols, different time frames. And that's why this external validation will be able to actually judge the true generalizability of the model, or we can say the real testing of the model in clinical setting or in the real world setting. The limitation of it is obviously it's difficult to acquire. Basically, as we all know, nothing good comes easy in life, right? So external validation, it's an essential part of the evaluation of AI model, but it's as you can imagine that it's difficult to acquire because you have to get the data from a different center, from a different setting. But it actually is a true simulation of the clinical deployment of the model. So while we are saying the validation and the testing, so what are we testing for? What are the issues that can creep up while training and validating the model, and what issues should be aware of? There are essentially three major issues that we are going to talk about. One is overfitting. So I'm pretty sure many of us who are here today could have been this child back in our board exam days when we used to cram all of our NCERT books for our board exams. I was one of them. So herein for overfitting, the scenario is quite similar. This happens when the model is actually too complex and the data is too small. And what the model does is it actually learns too much detail, and it learns word by word, we can say sentence by sentence, the entire training data in too much detail. And while learning that training data, it not only learns the significant information, it also learns the noise within the training data. And whenever a question or a data that comes from beyond the syllabus, out of the syllabus or outside the training data, and we put the model to test on a testing set that it has never seen before, the performance dips sharply, as you can see. So on the training set, the model performs very well, but on any set or any data that the model has not seen before, the performance dips sharply. So this is a result of too much training, we can say. And in scenarios where the data set is small, but the model is too complex and it learns too much detail of the training. So this we can see only while we are testing the data. That's why model validation is important. Another issue that can creep up is data leakage. So herein, I hope that most of us were not this child during our childhood. So this is particularly, we can say, like cheating. So this child already has access to the answer key. Before the test is put up, the student already knows the answer. So this is like unfair advantage to the model, wherein the training data itself has some information from the testing data set, and there is leakage of information. And while training on the training set, the model acquires this information and thus is bound to perform better on the testing set due to this unfair advantage. So this can happen, as I said, as a part of group splitting. So if there is information that has creeped up from a single patient, the information has creeped up into the training as well as the testing set, the model is bound to perform better. So another scenario to put this in perspective is one scenario that happened was researchers, they were training an AI model to classify chest x-rays for presence or absence of pneumonia. And it was a heterogeneous data set from inpatient and outpatient data. Both of them were included. And the model was trained well. And when they tested the model, they found somehow that the AI model was labeling all the inpatient data, all the inpatient chest x-rays as positive for pneumonia. And while on further analysis, what the AI model was actually doing was that it had learned the label of AP chest x-ray, that is anteroposterior chest x-ray, that shows the projection of the chest x-ray to be associated with pneumonia in the training set. So as you can imagine, so AP projection, AP chest x-ray is done for sick patients, ICU patients. So they were more prone to be having pneumonia. So herein the model because of the label leakage from the chest X-rays that were used for training, the model, instead of acquiring the actual information about the consolidation and the pneumonia patterns, it actually learned using the AP label. So some things like this, they have to be taken care of while using the training data and while pre-processing the data, and it's essential. Okay, and for data leakage, what will happen is we will see that on training data, the model is performing very well, and on testing set, on the at least the internal testing set also, the model is performing too well because of the unfair advantage. So another issue that creeps up, and that's a actually very real world problem during deployment. Dr. Vasant will have much more insight into it. So this is something known as domain shift. So this is differences in this creeps up because of the differences between the training and the deployment, or the external validation set, we can say. And there are some things that we can't do anything about. The demographics are different, the scanners are different, the spectrum of disease, the annotation, the way of annotation is different. So all of this is included in domain shift. There are techniques like domain adaptation that are being researched and that are being done to increase the performance of the AI model on the real world deployment data set as well. But this is another thing that decreases the performance of the model when it goes into the real world deployment or the real world clinical data. So these are the different and that's why model validation is essential before we start using it just on the basis of training, right? So this is just a summary of the issues that we talked about. Overfitting is when the model is too complex, data is too small. We can use data augmentation or a simpler model for overfitting. Data leakage is basically unfair advantage, and we have to be very careful with the splitting of data and the auditing of the training data. For domain shift, it essentially arises because of the different distributions in the training and the deployment set, and we can fix it by training the model on a diverse data set, multi-center training, and domain adaptation techniques, as I just talked about. So let's, okay. So before we move on to the next topic, this is another little MCQ. So if there is a model that shows such a performance that on the training set, there is a very high accuracy upon that's 99%, but within the internal testing set only, the accuracy drops sharply. So what do we suggest is the performance? What do we suggest is the issue here? Or there is no issue, we can just report the validation set performance and get a publication, and that's it. But herein we can see that the model is doing too good on training, and as soon as it's tested on an unseen data, the performance dips sharply. So it's because of overfitting or because the model is learning too much. Similarly, another scenario where the model is showing too much high accuracy on the validation set also and too much high accuracy on the internal test set also, that's most likely because of the unfair advantage or because of the data leakage between the training and the validation and the test set. Another scenario where the model is doing very well on the validation set, it's doing well enough on the internal test set, but as soon as it's deployed or as soon as we try to test it on an external set, the performance dips sharply. So this is likely due to the difference in the data, in the external testing data and the internal testing data, and this is likely due to the domain shift. Okay, so let's change gear from model validation to performance. And so far I've been talking about, okay, what's the performance? The performance goes up, performance goes down. But how do we measure the model performance? Is it just accuracy? So as we'll see now, is not for all the scenarios, accuracy will suffice. So the model performance goes much beyond accuracy, and we have to take care of these multiple performance metrics. But before moving into the metrics, let's talk about what all broad categories of AI of tasks is the AI being used for, or we can say, what are the major task categories in medical imaging for AI models. So these are the three categories of the tasks for images. So I'm talking I'm restricting my talk to computer vision problems, because in language models, which are based mostly on text, so there is the performance metrics and the evaluation are totally different. But for this talk, let's stick to the computer vision problems, the medical imaging problems, and we can broadly classify the tasks into classification, detection, and segmentation, although there are much more. But let's look at these three core tasks first. So classification is basically an image level label. So herein the model will get an input as the image here in a chest X-ray image, and the output of the model will be say positive or negative, or abnormal, normal, or active TB, or not active TB, something like that. It can have multiple classification labels as well, but for classification, it's an image level output. Okay. For detection, it goes one step beyond, one step further. Rather than just classifying that if it is positive or negative, it also tells us about the location of the abnormality by drawing a bounding box. So it tells us the location of the abnormality or the finding as well. Third task is the segmentation. So for segmentation, we can treat it as pixel level classification. For in the entire image, what all pixels carry the abnormality or the finding. So what the model will try to do is, it will try to delineate each pixel with the finding. It will try to delineate the entire finding pixel by pixel. So these are the three broad categories of AI tasks which are being used in medical imaging. And as you can imagine, for each task, the metric of performance is going to be different. Okay. So next we will deal with each task and their associated performance metrics, right? So let's start with classification. So this classification is particularly more familiar to us. So this classification problem is more familiar to us as radiologists because we have been dealing with all these true positives, false negatives, false positives, even before AI was there. So this is a confusion matrix, again, familiar to radiologists at our level. And some of the parameters or the metrics that we can apply from the confusion matrix can also apply in the classification problem as well. So for accuracy, all the true positives plus true negatives divided by the total, and sensitivity we know, specificity we know. So just a bit of a tweak here is sensitivity. We all know, we are familiar to sensitivity. Just the technical people, they will call it as recall, but it's the same thing. Okay. And similarly for positive predictive value, we are accustomed to using PPV, positive predictive value, but the tech guys, the technical people, they will call it as precision, right? But it's the same thing again. So these formulas, I hope you are aware of. If you're not, we can please give a read ahead with it. But for the talk, I will try to move ahead and try to move to the F1 score. So this is something that is more common in the technical fields rather than we as radiologists. So F1 score here tries to give us a balance and a single metric between precision and recall or sensitivity basically. So herein, let me just take you to the next slide. Yeah, this slide. So for classification metrics, accuracy focuses on the overall correctness of the model. It's best for balanced data sets. When suppose we have 50:50 ratio of the positive and the negative cases, but it can go very much haywire when there is a strict class imbalance, and the model can show very high accuracies even though it's performing very bad in a data set which is highly imbalanced. So our sensitivity, it focuses on only the performance of the model to find positive cases, and it's the caution is that it ignores the false positives. Specificity focuses on ruling out disease, and positive predictive value focuses on the correct positive calls. So all the first four metrics, they are standalone metrics, and they focus on one, we can say, one aspect of the performance. But F1 score tries to give us a balanced metric, which is best for imbalanced data. Even when there is a class imbalance, it gives us a balanced metric for precision and recall. And it is best used as a single metric for imbalanced data set. Although for all the performance metrics, we should have a look at all the metrics, but an F1 score is a more balanced metric. However, it is less intuitive. So just to give you a more perspective on this, if we look at this clinical scenario or this problem, out of the total 1,000 X-rays, 100 had pneumonia and 900 were negative. And this is quite common in our medical data sets where the positive data is mostly going to be less in number as compared to the negative data. So if there is a model which shows an accuracy of 90% just by predicting normal for all the X-rays, even if the model just says normal for all X-rays, it will have an accuracy of 90%. So this 90% accuracy may sound as very good. And as the first option says, it's very impressive, better than most residents, especially the junior residents. And it can be a very smart model. It avoids false positives. But what's the correct answer here? It's a useless model. Even with a 90% accuracy, it's a useless model. And that's why herein comes the importance of all these metrics and having a look at all these metrics and then deciding if the model is doing well or not. Just to go a bit more in detail, so this is the receiver operating characteristic curve. Again, for classification task, what happens is we want to look at metrics, look at curves or graphs, which give us a trade-off between the positive and the negative cases. So this ROC curve is one such graph. It gives us a trade-off between the sensitivity, the true positive rate, and the specificity, that is false positive rate, which is 1 minus specificity on the x-axis. And the each point on this ROC curve, it represents a different decision threshold by the model. So it's a confidence threshold of the model, we can say, and this can tell us how much of the model is a perfect. What is the performance of the metric of the model as a classifier? So if it's just a straight line, diagonal line, that is it's a random. That means it's a random classifier, and the more closer the graph is to the top left of the graph, it's a perfect class. Another curve that is used in classification tasks is a PR curve or the precision recall curve. Again, it gives us a trade-off between precision, that is the positive predictive value, and the recall, that is sensitivity. What we can see here between the two graphs is, just to give you a summary of it, is that the ROC curve, it is best for balanced data. But for the precision recall curve, it is best for imbalanced data. What happens is the ROC curves focuses on overall classes. Even if there is imbalance in the classes, the ROC curve will try to tell us overall ranking of all the classes. But for example, in medical data sets, in cancer data sets, since the positive classes are much less, we can use, and it's better to use a PR curve or a precision recall curve, because it only focuses on the positive class predictions and it is more sensitive to the false positives rather than the ROC curve. To give you more perspective about this is, if you look at this data set, again, a similar data set that I talked about earlier, which is a severely imbalanced data set, and the model is performing, it is out of the 20 positive, it is predicting only 5 as positive and 15 as false negative. So in such a scenario, it will have an accuracy of 95%. Although the model is performing very bad in detection of cancer, which can show up in the sensitivity, which is just 25%. And if we look at the ROC curve, area under the curve for the ROC curve, it will be 0.85, which is quite nice. But the true picture is given by the PR curve or the precision recall curve, which is just 0.3, which is very low. So in such a scenario, in imbalanced data sets, PR curve is the one that can tell us the better scenario. And in fact, the holistic evaluation of all the performance metrics is what we need. Quickly coming to the other AI tasks, that is for detection. So herein we have something known as intersection over union, which is an area of overlap of the bounding boxes. So here at the bounding box, one of the bounding box is formed by the expert, say the radiologist, and one of the bounding box is formed by the AI model. And what we look at is the area of overlap of these bounding boxes upon divided by the area of union, which we define as the intersection over union. So this is the basic metrics in that detection task. So this is the most important concept here. So if we look at the detection task and we try to define what is true positive, we can define true positive as overlap more than 0.5 or more than 0.6. We can define false positive as an overlap less than 0.5. This is just, we can tweak the thresholds. False negative is when the AI model fails to put on any box on the true finding. But can we think of what can we call as true negative? So for a detection task, there is no concept of true negative, because the entire background image is the true negative, and there is no concept of true negative for detection metrics. So that's why for the performance metrics for a detection task, we use only precision and recall and not other tasks like sensitivity, because there is no concept of a true negative here. Right, and there are other performance metrics like average precision, which is area under the PR curve. And in the interest of time, I'll skip a bit of it and focus on this curve, which is particularly important, that is free response ROC curve. Sorry for putting in so much graphs, but I promise this is the last curve. So this is the ROC curve that we just saw for the classification task, that is between the sensitivity, the true positive rate and the false positive rate. But for a detection task, we use something known as the free response ROC curve, wherein there is sensitivity on the y-axis and the number of false positives per scan on the x-axis. So herein, what it means is for each scan or each image, if we take in this metric, sensitivity of 80% means that the AI model is able to pick up 80% of the true findings at the cost of 13 false positives per scan. Means it makes 13 wrong detection boxes per scan, and then it picks up 80% of the true findings. So as a radiologist, I don't want to see 13 different boxes which are wrong and then see one which is correct, right? So for detection task, a much more important metric becomes the free response ROC curve. So just to summarize, the free FROC curve is for detection task, where the predictions by the AI model are multiple on a single image, where it can draw multiple detection boxes, and it is a much more usable, clinically usable metric, especially in medical imaging for detection tasks. Quickly moving on to segmentation, which is a pixel level classification, we can say. Herein we use something known as dissimilarity coefficient, which is similar to the F1 score for classification task. The area of overlap, the pixel-wise overlap. Now, this is the pixel-wise overlap by the total area of the prediction and the ground truth segmentations. Jacquard index is something just like the intersection over union that we just saw. So now these are pixel level segmentations rather than detection boxes. That's the only difference here. And Hausdorff distance shows the maximum difference between the distance between the two segmentations. This is just single distance, which is, it is sensitive to the outliers in the segmentations. So these are all different performance metrics that we can see for different tasks. Okay, I'm thinking that I'm beyond my time, but these are my last slides. And just to leave you with the entire thing. So in the last 20 minutes, what we have discussed is more about the technical evaluation of the AI model, but a critical assessment of AI model or AI software will go much beyond all these numerical metrics. So this is a very important, very interesting read. I request all of you to have a look at this if you haven't had a chance to have a read of this article. So this goes beyond performance metrics. The evaluation of AI models goes just beyond performance metrics. We have to see if the AI model or the AI software answers a clinically important context in our specialty, in a clinically important problem. And apart from all the steps that we have seen today is the data splitting, the validation, and the performance metrics, we also have to see other things like how does it compare with the conventional practices? How much does it actually add beyond the conventional practice? And does it actually help the clinical workflow or the diagnostic efficiency and so much and so on? Okay, so the key takeaways, never trust a single metric alone. Ask and know how was the data split, how was the model validated. Metrics for each task will vary. We have to look at it in a holistic manner, and a comprehensive model validation is what matters most, and it goes much beyond just numerical performance metrics. Thank you for your attention.
Thank you, Dr. Amit Gupta. That was a very good foundation course. I'm sure that all the participants benefited from what you kind of outlined here. So moving on quickly to the next topic. So when the focus of AI, the concept of AI, the clinical solutions have been, I think, hijacked by radiologists so far. But I'm seeing that there is a shift towards other participants in the ecosystem coming into taking up their own responsibilities, especially with the success of LLMs. With deep learning, it was all image, right? But with the success of LLMs and the vision language models, I see participation and leadership roles from other players in the ecosystem, the radiology ecosystem, be it the nursing professional, radiographers, even the revenue cycle managers. All of them are taking participation in that. That kind of is a segue to our next talk, which is titled, a very interesting title. It's called Digital Dexterity for Radiographers in the Era of AI. we have Mr. Sundara Kalyana. He's a clinical director of GE Healthcare Singapore to give this talk. Looking forward to this talk. The floor is yours. Thank you, sir.
Good evening, all of you. Thanks for the organizers for making such an event. Very fruitful for me as well. Just now heard Dr. Abid, a lot of interesting inputs. Is my audio is good, and as well as video, you can see the screen well?
Yes, sir. Yes, sir. Please go ahead. Very
Thank
clear.
you so much. Thanks, Dr. Vasan, for the introduction. This is something very interesting to talk about digital dexterity for radiographers. Of course, it's for the radiology, rather, I should say, the whole team in radiology department. We will cover a very interesting topic, but before there is a disclaimer for all of us, and I need to. Then what we will see today will be on what is digital dexterity, the essentials and outcome. AI in the imaging context, where all how it is. For radiographers, the common usage, some examples, how AI is useful, and whether AI is a friend or a foe. Of course, there are some concerns from many angles. Implementation challenges and way to overcome it is especially important for the radiology heads or the manager radiographers. Then adoption, changes and challenge, and something interesting, like Dr. Amit has spoken about weakness masked by strength. So I'll be also touching on that with some picturesque examples, and then we will see what is the way to change and how we can do that. What should be the shift in the category? A had been in our the buzzword since 2000s, but the early days started, if you go back in the histories, 50s onwards, some elements of AI had been there in radiology. You can see the earlier adapters of PACS has used AI to an extent, but I will not fully call it as an AI. It's a simple algorithm based many times. And in early 2000s, we have started seeing something like lesion detection with some algorithms with, say, early machine models. And of course, today we are sitting in an era of rapidly advancing AI in the field. Now, coming to the topic, what do you mean by dexterity? This is also a new word for me as well. I've not heard this word that popular maybe 4-5 years back. It is nothing but the willingness and ability and to adapt to the emerging advanced developments in the field of radiology using the digital tools. It's not only AI, of course, it covers a lot of other things as well. But what is essential requirement here to be a person with willingness and ability is the updation, adaptability, innovative mindset, and understand the workflow and the data management. And that's, of course, continuous learning. What will be the outcome? Definitely, it will give you very high efficiency in terms of operational cost efficiency, definitely enhanced patient outcome in terms of routine like radiation dose or the time or the contrast media usage, whatever it is here. And most important thing in the outcome, which is beneficial not only for the operator, not only for the facility, but also for the patient, is the consistency. A quick view, because I'm not an expert in the AI development models or something, but generally we can split AI into narrow AI and general AI. What they do is it actually replicates the human intelligence, and there is program which emulates the cognitional actions and problem solving, reasoning, perception, etc. If you look AI, it's a big chunk of thing. Inside that, if you look in, there is something, two different things which you can see. One is called machine learning and deep learning. In simple terms, machine learning work on supervised learning or unsupervised learning, but it's mostly on something like an informed decision. So it know the task what it has to do. So for that we use some data set. It's much simpler, but of course it can carry out a lot of work. It depends on what work you are what you want to do with AI, it depends on that. So ML is a great tool there. Coming to DL, it's much more deep, where we actually develop something called deep neuronal network, which is a self-learning system. We make the system to learn using standard data sets or the information. Then it learns itself and coming back with the desired result from whatever the data you give, or it is able to solve certain problems as well. Segmentation, Dr. Amita has spoken about different type of segmentation. I'm not going to get into this. So this is what overall AI in radiology. Just take an example how AI has helped in reconstruction in CT. This is just to say how the deep neuronal network works. The first thing is to develop a deep neuronal network, which is actually a program, a computer program, nothing more than that. For that, we once it's developed, what we give is we give a training data. This is where we actually was talking today about the quality of the data we give. For example, in this case, we want to create high quality images from a low-dose scan or a low quality data. For that, what we have to train them with high quality phantom images or a high fidelity filtered back projection, the trustworthy method of reconstruction for past more than 50 years with us. So using that training data, if you do training for the DNN or the deep neuronal network, this can give you a great result for creating images using DNN from even from a feeble data or a data which is not up to a very high radiation dose, or it really helps. So here is an example for you in front of you. It's a filtered back projection image, very noisy. We can actually use an algorithm-based reconstruction called iterative reconstruction. It helps a lot to reduce the noise, but the moment you move to the true fidelity, we can see that the image characteristic is highly improved. It keeps the same texture what is required, but at the same time, it handles a lot of other image quality parameters like noise, low contrast detectability, uniformity, and even artifacts. So what is important from this slide, the takeaway is training data is very important, and the outcome is completely based on the training data. Okay. Now, coming to AI in context of radiographers, where we use it. Literally tell you all across the department, even starting from scheduling the patient, scanning, acquiring the images, interpretation, which you have spoken now, and then reporting, which helps in standardization, follow-up and monitoring. Something very interesting, adverse events. If you have already data of the patient, and it can even alert before you put the patient on the scanner or give a contrast injection. Treatment response, which can go to the tumor board or the discussion for further evaluation and treatment pathway for the patient. Recommendation, it gives a lot of insights for not only for the radiology community, but also the treating physician or the surgeon. And AI, of course, has a great tool to communicate effectively with the rest of the fraternity who refer the patients for your scan. So altogether, if you look at what it do is it redefined the traditional work, it streamlined the process, it helps in substantial time reduction and overall optimize the scanner usage, which definitely will have business advantage as we are standing in a business world as well. So finally, takeaway for the radiographers as well as the radiologists will be improved quality and consistency and with high quality of care. One question I missed here is many times radiographers ask this, hey, do I need to be a computer expert to become a good radiographer in this era? No, you need not have to be. You need to be a good radiographer, but with some enhanced skill, that's all, right? So you don't have to go back and learn C programming. That's what I want to say. Now, let's take an example in AI, how we effectively use AI in stroke. From patient positioning, planning, scanning the patient, we are using all the AI tools. It know the task, what it's that it has to do acute stroke. Okay. So it identifies the protocol, identify the scan region, automatically help you to put the ROI to start the scan. Of course, here some manual process involved. You do the scan. Once that is done, it auto split the series, push to the workstation, then automated post-processing, which gives you the aspect score, LVO, large visual occlusion detection, and multiphysics CTA with color wizard, and automatic perfusion. And finally, it can auto push the report to the patient. But of course, all these need some protocol to be made, which is compatible with this workflow. So that is called on injection. We successfully deployed that. It works well. So overall, what's the benefit here? You have seen many of these workflow elements carry something called automatic. This is the word I was repeating. Of course, all of them uses the AI tools. So what is the benefit here? This is a classic example which I witnessed. A patient appeared in the hospital within 20 minutes of onset of stroke. Within 5 minutes, patient was in the scanner. We did this one injection protocol, which completed the data interpretation, including scanning, in less than 10 minutes. So get the aspect score. We got the multiphasic CTA, large vessel occlusion, and volume of the infarcted region was the penumbra. Then, of course, we got a perfusion map. Patient was shifted to the cath lab. Within next 10 minutes, the thrombus was retrieved. So this shows the power of AI, how fast we are able to use the technology in real life. Coming to another example in cardiac CT, which is not an acute setting or an emergency setting, where radiographer do a lot of job manually. We place the patient in the table, use the manual light, skin preparation, connect the ECG lead. And then you need to do a breath hold training for the patient, select which protocol you to use, prospective, retrospective. All these are overtaken now by AI. It auto-position the patient. You don't have to even connect ECG. You can go ECG less. Then you can go for auto-gating, which automatically select what the right phase to scan the patient for a task of, say, coronary angiogram. And auto-planning, everything happens. Then where to put ROI, when to start smart prep system decides. Then which recon to do. This is something many times you have seen going back and forth between the radiologist and the radiographer. Can you send me the other data set, this data set, do a multiphasic reconstruction? So you don't have to do all this. Smart phase is a one-stop solution for there. And something which is not available today is to, in the manual process, is to correct the residual motion in coronary arteries, which is not related to the ECG. There is a solution called snapshot phase with smart phase. And these all work with the radiographers and handle the patient. Once that goes for reporting, then we have something more in automated vessel tracking, which of course we had semi-automated models available, but now it has come to an era that we can have automated vessel tracking and stenosis quantification and even report generation. So it can handle variety of patient, all with consistency, irrespective of heart rate variation or with the reduced radiation dose, as well as the quick turnover with the patient. Now, we have seen the benefit. We have seen what is AI dexterity. We have seen the benefit of AI in day-to-day use. We will now just quickly look at whether it's what is the levels and limit currently we have as a group of radiographers, and whether it's a trend or a foe. This was a survey done in this among the 2,000 participants across the Europe. And the first pie chart actually shows the classification here. You can see majority of them, almost 58% had basic knowledge, and you can see 25% had an intermediate knowledge about the AI in radiology. That's a very interesting thing. But what is alarming here is the green part of the pie chart is 8.3% who never heard of AI. Okay. So this is the case in Europe. Of course, we can assume it will be the similar in other regions as well. So there need to be some programs which will help to make the awareness among the group of radiographers. And then there is a severe concern whether it is going to replace my job. This had been a question which has been asked, challenged, agreed, not agreed. Even Dr. Vasant also mentioned something on Elon Musk about some publication. And interestingly, this survey clearly says that majority of the radiographers agreed or strongly agreed, almost like accounting to almost 80%, that AI will only assist and will not replace them. Okay. And also many of them now feel that almost like 50% plus have agreed that it will help them to involve more in research and development, and it will definitely change their current role and the professional identity. Okay. The key takeaway is, despite the increasing awareness, the education is still lacking across the Europe. As I said earlier, it may be the same across the other region as well. Right. Now, once you are done, AI is important. Your team is aware of that, and you have brought something new to the department, how to implement it. This is something which I have taken from my, corporate managerial experience. This slide actually talks about how we can implement something when there is a change management process. You are going to implement AI into your department. So what you're going to do is you're moving from a current state to a future state. You cannot do it alone. You need both sides of people. One is the technical side and other is the people side, which is the people manager. So if both of them work hand in hand, then we can translate the AI process or implementation into the department to a great success. We can see when there is more of participation. If you see from 13 to 39%, the participation goes up. The success of the project goes by 3 times. And when you move from 70 to 80%, you can see the success goes by 7 times. So when we see that, more people involved and more the acceptance of the people to involve into the change management process and imbibe it, you can see the success goes up. And here is some statement from McKinsey's survey. They say 70% of the projects have failed or not achieved their desired result. This is a global data. This is actually alarming and concerning. We don't have the choice of, having this failure effect in our department because it involves a lot of money spent on implementing AI in department, either on an equipment or on the process, right? So what we can follow, there is a nice, interesting model called ATKR model. ATKR stands for awareness, desire, knowledge, and ability, followed by the reinforcement. Awareness talk about why now, what if, and then desire is what is in it for me. Okay, it's a choice of desire. Knowledge, what is that? Okay, what I need to know. Ability, whether I can. What will it be possible for me to do? Reinforcement is actually post-implementation and create trust on and then usability validation, right, or sustaining it. So this model is called ATKR model. I will take an example of ATKR model, which I successfully used when I have a customer who got a super premium CT scanner with 16 centimeter detector, 0.23 second, the best of the best in the class system. And a lot of AI tools were there. But when we were looking at the customer has a user of 10-year-old cardiac CT from another vendor, and he is fully, or they are fully adapted to that world. So this is the point. It's an exact scenario like a change management process. We want to implement the new system with AI capabilities. What I followed here is the ATKR model. What we did is we did a scoring, awareness. We got a score of 3. User know what is it. Desire, yes, all of them wanted to go to the next level of technology. So desire is very high. Knowledge, yes, it's not, they are not seen it before and worried about the result. And importantly, when it is going out of their comfort zone, which they were there for last 10 years. So knowledge is an important aspect. Coming to ability, yes, they are confident, they are smart radiographers can easily adhere to it and adaptable. Reinforcement, they know the awareness, they know the benefit, what it can bring to the table. So they are okay with reinforcement. That's how we scored it. Now, let's put that in the block graph here. And if you go from your left to the right, you just see the lowest score is on the knowledge, which actually is called the barrier point. So whenever you do an ATKR analysis, look for the barrier point. This is the point which will help you to address and successfully implement the change in the management process while you are implementing AI in your department. Okay. So ATKR point, whereas the barrier point can be anywhere in the ATKR graph. Okay. It need not have to be in one of the elements, or it can be in multiple elements as well. So take the first one, which one has scores the lowest in following ADKAR. Okay. Now, when you are implementing it, 2 things are required. One, you as a leader, you as a manager, when you are effectively leading the teams, and when you as a user, when they are making a change themselves, we should have a common meeting point. It can be anywhere in this model, right? There should be a common meeting point that makes the process to be successful and implemented in good terms. But as a leader or a manager, of course, you need to be a communicator, a liaison advocate, resistance manager, and coach. Let me combine these 2 models. When you can use these effective qualities, it's called clerk model. So you can have this clerk model with the ATKR model on X and Y axis. as a communicator, when you actually have awareness problem, that's where you can start with. Or you can be a coach when there is a issue with the knowledge. So combining these two will help you to happily implement the change management process when you are implementing AI in your department. Okay. Coming to adoption and the challenges, first of all, there is a workload change, right? You should be able to see what is the current ecosystem and whether the ability of the current system to include this workflow inside. Okay, this is something very important. Data quality. Does the AI bring improvement in the quality of the process? If not, of course, it's a tool, but it's not going to improve anything. Right, with diversity, I think when the talk started, Dr. Vasant mentioned this, it's important that it should be applicable across disease patient type and of course all the ethnicities as well. Clinical utilization, decision making, how that is going to change the treatment pathway. Safety, regulation, and ethical elements. We don't have to say anything here because we have to be fully compliant on these things as per the local governing bodies or the government rules. Future expansion, interdisciplinary collaboration, and it expands a lot of pathways for research and innovative ideas. So whenever you are selecting an AI model or AI workflow into your department, just think of this, how we can adopt this and which all points are relevant for you. All of them may not be great selection for a particular thing, but whichever fits well can be of great use when you're adopting something new into the department. Now, coming, you have spoken great about, we have seen what is AI, what is dexterity. We have seen different elements, how to overcome if there is a challenge using the ATCA model. Now, coming to something weakness masked by AI. You have been seen gaga about AI all around. There are certain pitfalls, rather, I will say, we have to see common areas of failure. Let me start with interpretational failures. I think Dr. Amit has spoken about overfitting here as a classic example. Pulmonary thromboembolism is not detected by AI. It's a case of overfitting, right? Certain things like age-related change, anatomical model, or pathological variant, or surgical change not detected. Patient who presented with 8 months back with subdural hemorrhage, and you can see it transformed to hygroma, but AI detected it as intracranial bleed, right? Artifacts. Sometimes artifacts also can be challenging. Here it is reported by AI in the heat map. You can see some red spot here. This is reported as bleed, even though the radiologist was smart enough to repeat the slice or the scan, and he was able to say that there is nothing. It's absolutely fine. Many times devices come into the play, which is very interesting. The data subset for validation is very minimal, and that is why this often comes as a big challenge in the failure of AI in implementation. There is something like a rib fracture, but interestingly, this is nothing but ventricular peritoneal shunt being seen there, right? This one, previous studies, availability of that. A small colloidal cyst, which is reported in the previous scanner 1 or 2 years back, and the present AI model reported it as intracranial hemorrhage. Luckily, the radiologist had access to the previous data and was able to correlate back, and of course, with manual interpretation, was able to override it. The other one, which is a very common thing, satisfaction of search effect. When you're searching for something, AI algorithm search for something, it stops there. It say, yeah, it's there. Sometimes it misses. This is a classic case where there is an intracranial bleed, which was detected on the left side, but there was another one which was on the right side. The right side one was totally missed. This was actually taken from this AJR article, maybe in 2033 or something. A very nice article covers that on interpretational inabilities of AI. Some failures in workflow and procedure mostly connected to the radiographers is, for example, when I use AI tool for positioning head scan, unfortunately, the patient moved her hand, maybe making a phone call. I don't know what she was doing. So what has happened is the expected center of line need to be at the blue line. But what has happened is the system auto-positioned the patient to somewhere else. What is the impact on it? It will increase radiation dose to the patient, inconsistent image quality, right? Something more, which is very common, you get patients wrapped like this in the department coming from the ICU with a lot of tubes and other thing. AI completely failed. It's a chest scan. happily detected the abdomen, right? The second one is the task-based optimization. You are not defined the task well in the system, and the optimization input is not given in the data set train. So what has happened here is a head and neck angio. We have used head angio as the task. What has happened is, but we scan the head and neck, you can see the noise index is something like 42 here, and which is 11 actually at the desired area. So is it not interpretable? Of course, it may be interpretable, but at the same time, you can see that there is a lack of task-based optimization problem. User override, mismatch and partial loss. Here is a cardiac examination. We have implemented AI tool successfully, but the radiographers always think, hey, or the radiologist does that. I won't always scan from 40 to 90% for every patient, even though the task was just to do successful coronary angiogram. So when they have gone, used AI partially and overridden that AI with a manual gating trigger, what has happened? The result was something like this. It was something like a false disease. We don't know what is that. And interestingly, we did manual recons to go back into the data set and able to see it was absolutely normal, right? Sometime a recon related, I put one example here. There is a small dental implant. When AI recon did, the recon totally missed a segment of the image, right? So I don't say that AI is bad, but I am putting some classic example. This is to make sure that the radiographer, the radiologist are aware of when to look at, go back to your data and go back to sometime to your basics as well. Now, coming to the last portion of that, are we ready? Interestingly, when I did my diploma, post-graduation diploma, way back 25 years back in Sri Chitra or in Trivandrum Medical College, we are not even seeing computer. I started seeing my first computer in Sri Chitra, right? So we need a shift in curriculum. Now, it can be in two ways. One, it's through the education starting from the day first onwards, when the students are in their first year to the third year. Different modules are suggested. This is from publication from Australia. This is what the suggested curriculum. It looks pretty nice. It covers almost everything. But as a practitioner, as a practicing radiographer or a radiologist, where we should start with, that's also being seen in one of the articles which clearly tells about different elements from basics to governance, ethics, and clinical AI interpretation. So these are the topics which we may have to include in our continuous education. So what I suggest is maybe forums like this can start with their certification courses at multiple levels, enhanced lab or the augmented lab education, and of course, industry, of course, do the maximum development and investment on it and continued collaboration with them. If you look at all this, there are certain barrier points which makes you to have an effective curriculum in place, limited mentors, time constraint, limited interest, and variability of trainers. And of course, AI is developing super fast. And here are my references used. And to go to the summary, what is digital textbook? We have seen what is the different type of models there, and in the workflow, how we are able to implement this successfully, and to if there is a challenge in implementing it, what we can do using that curve model, barrier point, etc. Adoption and changes in the context where we need to be choosing what we need to be choosing when we are having an AI model in front of us. Of course, we have seen the little bit negative side of that as well, and where we need to be cautious about. And of course, the last portion was on shifting curriculum for both students and practitioners. In my overall point of view, is AI in radiology is an adaptable, trainable, reliable, compliant, a guarding companion, and of course, a playful companion, and a lovely partner with you. Thank you so much.
Thank you, Mr. Sundar. That was an excellent talk. So it was like having a multi-cuisine feast. It had physics, it has technology, it had clinical medicine, a lot of change management. Thank you so much for the time and the presentation. I will hand it over back to Professor Paneerselvam for the rest of the proceedings.
Thank you, sir. First, I would like to thank our chairperson, Dr. Vasant sir, for introducing the speaker and about the topic. He itself has explained about the key points about the artificial intelligence in the initial phase, and followed by first speaker, Dr. Amit Gupta sir. Sir, I would like to say 2 points. See, understanding the artificial intelligence and its application is one aspect, but correctly pointed by you, validation is very important, and particularly the AI models. See, for how we actually validate the internal, or for example, the reports done by the radiologists, you know that there are two validation, internal validation and the external validation, particularly when we go for the quality process like JCA and all. So we have internal and the external validation. Similarly, you have highlighted about the superbly about the AI model validation. Apart from that, you also explained about the performance metrics, which is also very important because the quantification, that part, that is the measurable elements aspect is also very important in contributing this validation process. As a physicist, what I would like to say is, it is very highly informative session what you have done, but of course I have to accept it is complicated, but you made it very simple. That's more important. Okay. So that aspect I would like to extremely thank on behalf of the show team, as well as of course from Gapio team. It was a wonderful session, sir. Thank you so much for doing this. And of course, I would like to boldly and openly say that I have learned a lot of things today from you. Thank you very much, sir. Secondly, I would like to thank, of course, is my friend, good friend, Mr. Sundar Kalyan. Actually, he was telling about very important point. The terminology I also learning today only, to be very frank, digital destiny. So people always like to be in the comfort zone. Particularly, he was highlighting about the radiographers. Definitely, I also like to insist that they have to come out of the comfort zone. First thing, as he rightly pointed about, the willingness of adopting the new technology, as well as what you call first aspect is the willingness, and of course the second aspect is adopting the newer technology in AI. As Sundar itself, as he was mentioning, he was a student 25 years before. Right from that time, we are seeing him. So that is the thing. He itself set an example that yeah, we have to come out of the comfort zone, and he has grown to such a level. Thank you, Mr. Sundar Karan. And of course, I would like to thank that you have put a lot of case studies. That is also very important, which we have understood the application aspect of the AA is utilized in the clinical practice, that is in the day-to-day practice aspect. So I would like to thank both the speakers for a wonderful session. This is actually an evolving technology. We should also cope up with the newer technology and learn actually. Thank you to both of you. Now, it's a time that I would like to hand over. I invite Dr. Vasant sir as well as Mr. Suresh for the question and answer segment. Over to you, both of you, sir. Thank you.
Do we have any questions, the organizers from the audience? I don't see any of the questions in the kind of any chat box or the question box. So if it's not there, I have in fact a question each for both the speakers. So first to Dr. Amit Gupta. So Dr. Amit, again, the talk about radiology, AI, radiology being at the forefront of AI, I have been hearing it since 2016, 10 years now, right? And now I've seen the rise, fall, and the re-rise of AI in radiology, right? Parallelly, what's happening is the clinical fields, the nephrology, the cardiology, pathology, all of them are trying to progress and overtake radiology. They are successful in a certain aspect and not in many. So what is your bet on, right? Where do you see this going at a very, very high level? Like, is this different this time around, or is it going to be the same, right? The new way of vision language models, foundation models, or in fact the agents, AI agents is the new kind of buzzword. So how do you see it panning out? Any initial thoughts? I know we can't make any guess. It's just an educated guess. So what is your gut feeling?
Thank you for the question, sir. And it's an interesting question, and it's an evolving question, evolving debate in itself. But being a radiologist and being a, I'm still at an early stage of my academic career, and so I have this problem of being hopeful. So I'm hopeful, and I see AI.
Hopeful of radiologists getting replaced, or
No.
or
Hopeful
a
of
radiologist
radiologists,
staying.
hopeful of radiologists, coming out at the forefront of it, at the top of it, and maybe in a better manner than we currently are. So, so a lot of our work here at AIMS also, it's we are trying to do is to make our specialty more patient facing, right? Rather than we currently are. And similarly, I think that with the AI taking up the mundane stuff, the routine stuff, uh, we as a specialty, we will have more resources and more time to focus on complex tasks and on we can say humanly tasks, wherein we are a part of multidisciplinary teams for precision medicine, for patient counseling, and so on. So that's what I see, and I hope that the
This
specialty
time
goes.
around, things are different.
Yes.
Okay, so coming to Mr. Sundar, right, Mr. Sundar, again, you're part of GE Healthcare. So I have worked very closely with GE Healthcare team. I worked at Margin Imaging for a very long time, and Margin Imaging is purely a GE site. And I've met several of your healthcare leaders, AI leaders, everyone, global healthcare leadership. One thing I liked about GE is that they take very slow but measured and calculated steps, right? They didn't plunge into the AI wave that was coming up and trying to do a lot of stuff. But whatever they have done, they have taken the non-diagnostic parts, the image reconstruction part, and very successful. What's new, right? What's the bet on now this time around? Are you going ahead and building something for radiographers specifically on LLMs? Is that something that you can share with us without risking angering your bosses? Something that you can share, some kind of a trailer?
Thanks for the question, Dr. Vasant. Uh, of course, Dr. Mahajan, I know him from 1998 when he started his first MR. I was the apps trainer for him. So great place. Great regards to him. Now, coming to your question, of course, see, you can see there are a lot of technology shift is happening today, right? So it was a period when we have a single slice CT. To today we have Y detector, then we have photon counting. So technology is evolving, and we need it. I'm talking about CT and MR also same, right? You can actually see or anything in imaging you take. There is a lot of changes which has happened. So the changes on the side of the hardware and the capability, how this can be more beneficial and multiplex the usage of that technology, right? That you take as technology part of it. And along with that, there are a lot of elements which will make the technology friendly and useful in today's day-to-day context with consistency, which is an important thing, and beneficial. So this is where AI technologies are evolving, and this is continue to evolve. But I don't have a one sentence answer for you in this case because there are so many things are around. So each and every modalities, each and every type of imaging systems which will have its own addition coming over the years, and this will be rapid also, right? Some way it can be slower because of testing validation, as we have to comply with many regulatory authorities that we don't want to get into capital punishment for that. So as an organization, we of course will every organization in that context will be doing a very cautious approach, but definitely there are so many things are going to come up. It will change. How it is going to change, we don't know really, but there are many things which we know, but cannot go to the nitty-gritties as it's not intended.
I know. Thank you for that answer. I think we have one question here from the audience, which is kind of how is AI changing the traditional workflow between radiologists and referring physicians? I think this is around maybe the report generation part, and probably hinting at are we using LLMs and building some LLMs for the communication? So Amit, do you want to take this, right? Do you want to kind of talk about, do you see any change happening in the workflow between radiologists and the referring physicians? Like the workflow is physician gives a request, goes to the radiographers, they do the scan, the images come to you, you report the scans, and the reports are presented as a document, text document. Do you see any change happening now, or do you foresee any change happening in the future?
Yeah, that's actually an interesting question, and a question that we have been actually working on. So, as you know, so in India, it's a patient first workflow, right? We give the report as a document to the patient first, which is quite different from the Western scenario where the report is first seen by the clinician, and the clinician then tells the patient about the what are the findings and explains the report. So herein, the patient gets the document which is written in English and medical jargon. It's very tough, and they end up either Googling it or now Chat GPT and whatever information that they can get. So in the same vein, we had
Are they
actually.
getting better information from ChatGPT than doctors?
So actually, we did one study within AIMS for oncology patients. Basically, we did it, sir, and we tried to simplify the reports.
Report. Yeah.
In under the supervision of a radiologist using ChatGPT, and then give it to the patients. And so we found actually some instances of errors in the simplification, but because it was being done under the supervision of a radiologist, so whatever the patient was given, the information the patient was given was correct. But we found some instances of errors. But the workflow, how it changed was that there was we used a questionnaire, patient questionnaire, to assess patient simplification and patient education, patient knowledge. There was obviously a significant rise because all those English written medical jargon reports, they are barely readable even by a literate patient, let alone an illiterate patient. So there is definitely a scope for it, and we are actually trying to change the workflow wherein the radiologist gets a first patient facing role, more patient facing role, and then the patient is more informed about the findings, and then the patient goes and sees the referring physician.
Yeah, that will be interesting, but I'm sure, the workload for radiologists in
Yes.
institution like AIMS is so much.
Yeah.
It's going to be tough for them to spend that time.
Yes.
So we don't lack radiologists. We lack, I think compassion. That's a different talk altogether. There is another question. So, which is kind of what level of AI literacy should physicians have these days to better prepare them for future? And also, there is a follow-up question which says, are we nearing a future? Oh, no, the different question. The first one is, what level of AI literacy do physicians need to have these days for? So I'll take that one.
Yeah.
Because, I think today the important thing physicians should be possessing is openness, right? Openness to information, openness to explore, openness to spend time on understanding stuff. I wouldn't recommend anyone to do a, proper coding courses. You don't need to learn Python, you don't need to learn Java, anything, any of these things today. In fact, engineers also should stop learning coding now with all these vibe coding happening, cursor, ChatGPT writing the codes, and it's kind of scary for unfortunately engineers than doctors today. So I don't think you need to do any computer related courses, but physicians should be aware of what's happening, read uh, journal articles, the top cited one, the top referenced one, attend webinars like this, spend time. There are several podcasts running in YouTube, Spotify around health tech. Whenever you have time, pick the best one based on your discipline and interest. Try to follow them, spend time on them. A couple of Netflix episodes you can skip for a few podcasts that will be interesting for you. The next question is, are we nearing a future where scans will be interpreted without human involvement? I think that goes to Amit again. I have my own opinion there, but I want Dr. Amit Gupta to answer that.
So just to add one point on the last question, so there is a lot of integrative stuff that we can find now, wherein the stuff that is meant for physicians, which is also having some technical stuff, like we can have radiology. In radiology, if I talk about radiology, artificial intelligence journal, there is a lot of integrative stuff. So such stuff is very informative, and
Yeah.
it's a nice balance between the clinical part and the technical part. And coming to the next question, I really hope not, but I think, sir, why don't you take it? I think you have a better insight
So
in this.
I think I've been talking about this. In fact, I think in the 2018 RSNA, Eric Round Theater, I stood up there when the AI was being. That was when Jeffrey. It was fresh of Jeffrey Hinton asking hospitals to stop training radiologists in
Yeah.
2016. Just 2 years after that, I went ahead and said that it's not going to happen in our lifetimes. Even today, I'm sure that it's not going to happen in our lifetimes, because when you think of radiologists interpreting scans, you go to any radiology department and look at the depth and diversity and the detail to which scans are being interpreted today. And AI is still struggling with chest x-ray, right? 2015 to 2025, there is not even one single AI solution that can comprehensively report a chest x-ray without a human involvement 100% of the times, right? And there is of course, no FDA approved chest x-ray AI solution that can find more findings on chest X-ray. So this is not going to happen in our lifetimes, even with or without AGI, artificial general intelligence. Uh, Radiologists will be there. They'll be reading scans, maybe faster, smarter, but definitely they are going to be around there. Yeah, and I think this will be the last question because we are running out of time a lot. Should clinicians now learn to validate AI generated radiology reports before clinical decision making? Uh, the question is slightly kind of unclear. I understand that the question is intended around if there is a radiology report which is generated with any AI based tool, with or without radiologist assistance, should clinicians now be reading radiology or understanding radiology to validate those reports? Is probably the sense that I'm getting it from the question. I think that's far fetched unless clinicians are getting autonomous reports, right?
Yeah.
So as being asked in the previous question, if you are getting a report from an autonomous, I think some institution, even in AIMS, I think the normal chest X-ray reports are not reported by radiologists.
Yep.
It's just being generated by AI. The logic there is it was never reported. Right? It was never reported in the first place. Why don't we just give something where there was nothing?
Yeah.
So that's AIMS. AIMS is a completely different scenario. The physicians at AIMS have learned over the period of time to interpret imaging studies, but clinicians, what they can learn is to a basic level, interpret images, which is part of their training program.
Yes.
You can spend more time with the radiologist to understand how images are interpreted would be more valuable than trying to interpret radiology AI solutions. You'll have your own battles to fight now, your own tasks. If you are a physician, your own clinical history taking capability, prescription generating capability are being kind of now quarreled by multi-billion dollar companies with AI scribes. I think you should learn to validate those solutions. The concepts are very similar to what Dr. Amit Gupta has talked, in his presentation. But begin with your own domain-specific AI solutions. Then those principles apply to radiology AI solutions also. With that, I will kind of hand it over back to Ashutosh Sahu for taking this forward.
So, before that, I'd like to introduce him.
Sorry,
It's
I've
okay,
known
sir.
Ashutosh for quite some time. It's like handing it over to a friend.
It's
Sorry.
fine, sir. It's fine, fine. Actually, it's a time for closing remarks by Dr. Ashutosh Sahu. Dr. Ashutosh Sahu is a fellow in emergency trauma and acute care radiology at the University of Toronto. Dr. Sahu pursued advanced training in neuroimaging at King's College, London, under the prestigious Commonwealth Scholarship. Next year, Dr. Sahu will be joining Boston Children's Hospital, Harvard Medical School for a fellowship in pediatric radiology. Following this, he will assume the role of an assistant professor in the Department of Radiology at the University of Michigan Medical School, where he will be working in both pediatric and cardiothoracic imaging. Dr. Sahu's clinical expertise is further strengthened by a robust research portfolio with several peer-reviewed publications, numerous conference presentations, and ongoing research project. Welcome, sir. Dr. Ashut Sag, over to you, sir.
Thank you, Professor Selvam. A big thank you to our speakers, Dr. Amit Gupta and Mr. Sundar Kalyana, and to Dr. Vasant Venugopal for leading today's wonderful session. The Q&A session was also very wonderful, very informative, and everybody could get a gist of what is actually going on in the field of artificial intelligence and radiology. And also big thanks to the GAPIO and the GAPTIO teams for organizing this excellent event. And to our audience worldwide, thank you. Thank you for your time and participation. And we look forward to seeing you at a future GAPIO webinars. And thank you. Thanks a lot. Thank you. Stay safe and take care. Bye.
Sir, on behalf of GAPIO, I want to thank DocPlexis, which is the digital outreach partner for this online session of GAPIO. DocPlexis supported to make this session by designing creatives, providing its digital platform, and by disseminating the information about this session to its database of over 380,000 doctors of 99 plus specialties. And DocPlexis team, which believes that a well-informed doctor is positioned to make better clinical decisions. I would like to thank Mr. Nitin and Dr. Shetilon for being instrumental to arrange this session technically. Thank you so much, DocPlexis team.
Thank you so much, sir.